for CCNC. My name is Kim Weichel. I'm co-chair along with my husband Carl of the Contemporary Issues Forum. We meet twice a month on Zoom, usually from noon to 1 throughout the fall. And let's hope we can meet in person in the spring. We'll see. So I firstly want to talk about our next program, which will be on Sunday, October 24th. That is UN Day. The program is called UN Day Forum, Taking Action on Climate Change. Because it's such a timely and special program, a colleague from Cedar Lane and I have put together a large coalition of organizations, many UU churches, Cedar Lane, Altos, Fairfax. Sounds like somebody needs to
If we could
mute.
ask everyone to please mute yourselves as a courtesy to our speakers, that would be great. And we are recording today.
Thank you. So again, it's a large coalition, about 6 UU churches, along with the UN Association of the National Capital Area. We've been able to invite some high-level speakers, one of whom works at the State Department directly on COP26. The president of Cedar Lane will be speaking, and he works directly with climate envoy John Kerry. So we have a number of great speakers. That one CIF program will be 4 to 5:30 on Sunday, October 24th. The difference is the Zoom link will not come from our church, so you'll have to register. It's free. All the information will be in the e-weekly this Thursday and the next 2 Thursdays. So you'll learn more information about it and how to register. So I'm delighted to welcome you to today's program. Several months ago, I saw an excellent and long book review in the Washington Post on this very topic and read it with great interest, and then realized, wow, it is written by our own Susan Okie. So I contacted Susan. Susan and I are both altos in the choir. And I asked if she would give a talk on this very important topic, and she agreed. So here we are today. So Susan is a former Washington Post medical reporter and a former contributing editor of the New England Journal of Medicine, and of course an RRUUC member. Trained in family medicine, she volunteers as a safety net clinic in Montgomery County for uninsured adults and teaches medical ethics and patient interviewing at Georgetown University School of Medicine. She'll be talking today on deaf ears, medicine's historic neglect of women's health. She'll speak for around 25 minutes, so I ask that you put in questions and comments in the chat, and then we'll have plenty of time for discussion of those questions and comments later. So, Susan, delighted to welcome you. Thank you for joining us.
Thank you so much, Kim, for inviting me and for your introduction. And thank you also to Carl.
Again, if we could ask everyone to please mute your microphone out of courtesy to our speakers, and we are recording today's session. Thank you.
Thank you also to Carl for doing the tech behind the scenes. And I want to give a shout out to my fellow choir member, Diane Bean, for her invaluable help during some of my research. First, a little bit about where I'm coming from. As Kim said, this talk grew out of my reviewing for the Washington Post a book entitled Unwell Women, a work by Oxford researcher Elinor Cleghorn that gave me a new understanding of why women's diseases have so often been misunderstood, misdiagnosed, and understudied. When I started Harvard Medical School in 1974, I was part of a Harvard Med School class that was 40% women. That was a record high for the school at that time. And the women and the men in our class had come of age during the advent of birth control pills, the women's movement, and a separate national women's health movement launched by the book Our Bodies, Ourselves. We were optimistic that our generation of doctors could change things. And indeed, 48 years later, some aspects of women's health have changed for the better, as I'll describe. But as a nation, we're still facing some of the same problems. High rates of maternal and child mortality in our rich country, serious health disparities between people of color and white people, and a lack of access to health care for the uninsured and the underinsured, which includes many immigrants. In addition, a number of diseases that predominantly affect women remain poorly understood and understudied, which can lead to their delayed diagnosis and inadequate treatment. And as we know, Americans and their political parties remain divided over allowing women autonomy over their own bodies when it comes to reproduction. The legality of abortion is threatened, and access to sex education and contraception remain problematic for many. Cleghorn's book is social history, not a science book. Its subtitle is Misdiagnosis and Myth in a Man-Made World. That word myth is key. The book shows how false beliefs about the female body and sexist attitudes about what women are capable of handling and accomplishing guided doctors' thinking through most of medical history. From the time of the Greek physician teacher Hippocrates around 4th century BC, those false beliefs continued over the centuries, even into the 20th century. For instance, the myth that women are incapacitated during menstruation held sway, keeping them out of higher education, out of the workforce and the professions, even after some of the first women allowed to become doctors in England and the US conducted research showing that 97% of women are not limited by physical or emotional symptoms during their periods. Fake news is hard to kill. Even in 1970, surgeon Edgar Berman, who was a member of a Democratic Party committee on priorities, pronounced women unfit for leadership positions because of their, quote, raging hormonal imbalances. I'm going to briefly trace how beliefs about women affected doctors' practices over time. Then I'll talk about women's health in our lifetime, including some of the advances we've seen and the challenges we still face. For most of the historical period I've mentioned, women were not allowed to become doctors. Elizabeth Blackwell in 1849 was the first woman to obtain an MD from a US medical school. But the midwives and local healers who treated the poor and delivered their babies were usually women. These women's sex, their knowledge, and their position as healers often made them suspect in the eyes of religious leaders and other members of society. In times of plague and during the Inquisition, midwives and healers, especially if they were women over 40, were often accused of witchcraft. During the 16th and 17th century in Great Britain, 80% of the roughly 200,000 people executed for witchcraft were women. Hippocrates and his followers taught that a woman's uterus could escape from its normal position in the pelvis and wander through the body to interfere with her liver's function or even bump up against her diaphragm, stopping her breathing. He thought a young girl's uterus could sicken her from too much menstrual blood, while an older woman's could cause illness by drying out for lack of sexual relations. The word hysteria, from the Greek word for uterus, hystera, was coined to describe the maladies the organ was believed to cause. Hippocrates had never seen a uterus or dissected a body, but doctors and surgeons continued to believe for centuries, even after dissections provided a knowledge of anatomy, that women's reproductive organs were responsible for most of their physical and mental complaints. You can hear the echo of Hippocrates in Freud's use of that same word, hysteria, to denote a mental condition, usually in women, that featured emotional excitability, anxiety, and physical symptoms that doctors often regarded as feigned. Throughout the 19th and into the 20th century, doctors in the US and England regarded the white women they typically treated as fragile beings who required early marriage and frequent childbearing as a prescription for health. Doctors had no idea how a woman's reproductive system worked, and by the late 19th century, some surgeons in England and America began simply removing the ovaries of women who suffered from heavy periods or no periods, or general exhaustion, or even masturbation. They sterilized them. In contrast, Black women were viewed as tough enough to endure hard labor. Enslaved women were forced to have frequent pregnancies starting very young and to give up their children to be sold. Black women were also believed to feel less pain, racist assumptions that echo through medical practice today, as Cleghorn notes. In 1845, James Marion Sims, a doctor in Alabama, performed numerous experimental operations on 3 enslaved women, always without anesthesia. These women had suffered injuries during childbirth that caused urine to leak from the bladder into the vagina, and Sims, wanted to invent an operation to treat this then common problem. However, he inflicted unimaginable torture on the 3 women who were powerless to refuse. One of them, Anarcha, underwent his experiments more than 30 times. I've always regarded Margaret Sanger as a hero, the 20th century nurse and activist who published a newspaper for women with information on how to prevent unwanted pregnancies, who opened her own clinic in Brooklyn, who argued that women should have charge of their bodies, and was tried and jailed under vice laws. But we forget that Sanger and her British counterpart, Marie Stopes, were active during the period in the early 20th century when eugenics was a powerful movement in both countries, as well as elsewhere in Europe. Sanger, who opposed illegal abortions, advocated, quote, birth control, a phrase she coined, to allow women to avoid unwanted pregnancy. But she also believed that birth control should be used to prevent the births of, quote, children born feeble in mind and body. Stopes, too, saw birth control as an instrument of eugenics and, quote, racial betterment. Forced sterilization became legal in the United States in 1907 and grew more widespread after 1924, when the Supreme Court upheld its legality in the Virginia case of Carrie Buck, a 17-year-old rape victim. Sanger supported forced sterilization for, quote, the insane, the feeble-minded, and anyone with inheritable or transmissible diseases. In the 1930s and 40s, thousands of poor, Black, Indigenous, and Latinx women were forcibly sterilized. In California, the surgery was performed on Mexican women, viewed as, quote, hyperfertile or mentally deficient. In North Carolina, 85% of, quote, mentally deficient people sterilized in state institutions were women, and a majority were Black. Mississippi legalized the performance of sterilization of patients by surgeons without the patient's consent after childbirth or during other operations. Learning some of this history has made it easier for me to understand the reasons for continuing distrust in the medical system, particularly in Black communities and among some of the Hispanic patients whom I treat at the clinic where I volunteer. Most of us have heard about a few historically glaring ethical lapses committed by researchers, such as the notorious Tuskegee study, in which Black men with syphilis were studied for years without being treated for the disease. Or the case of Henrietta Lacks, a Black woman whose cancer cells were used without her consent at Johns Hopkins Hospital to create a line of cells whose value for research was incalculable. But our country's record of forced sterilization and the fact that Sanger herself in the 1930s tried to establish a national birth control program for Black women led by white doctors helped me to understand why Black women might remain wary today of a health program or clinic led predominantly by whites. Regarding birth control, Angela Davis wrote, "What was demanded as a right for the privileged came to be interpreted as a duty for the poor." I'm going to take a sip of water here.
Susan, so interesting and challenging. We know some of this history. It's important to hear this indeed. I'd like to ask you a question or two, but firstly, let me remind people to please put questions and comments in the chat box. So how has women's health changed during our lifetimes? And what has been the recent track record of the US medical system?
Well, sort of starting with our lifetimes and going back to earlier in the 20th century, which is, when my lifetime was kind of in full swing, the word hormone entered the medical lexicon in 1905 to describe chemical messengers that were made and released by organs or glands to regulate body processes. For women, the 20th century became the era of hormones. At last, scientists learned how the ovaries worked, what triggered a menstrual period, why women go through menopause. The, quote, female hormones, estrogen and progesterone, were directing the orchestra. The discovery of these hormones and the development of drugs to mimic or block their effects led first to the wildly popular drug Premarin, an estrogen product promoted for menopausal women, and later to the development of oral contraceptive pills, injectable or implantable contraceptives, and the drugs currently approved by the FDA for medical abortions. Without question, these inventions changed, and they are still changing women's lives, not only in the US, but in many countries. Menopause is a natural process, not a disease, but the gradually declining production of female sex hormones that occurs during menopause causes most women to suffer hot flashes, changes in their periods, and often sleep disturbances and mood swings or depression. For most, the symptoms are temporary, but for some women, they're more severe, and sometimes they last for years. Premarin was marketed in 1941 to relieve, quote, severe menopause symptoms. But as Cleghorn reports, it was also, quote, touted as a relief for husbands burdened by moody, quarrelsome wives. Keep in mind that during the 1940s and 50s, a brain operation called prefrontal lobotomy was also promoted for managing depression and other mental illnesses. And women made up 75% of the patients who received lobotomies from two of the surgery's prominent practitioners. The early antidepressant drugs that became available in the 60s had more side effects than the ones commonly prescribed today. And women suffering anxiety were often prescribed tranquilizers that could be addictive, like Miltown and Valium. Certainly, taking a pill containing female hormones seemed preferable. Besides, Premarin, it was promised, would keep women, quote, feminine forever, according to the title of a book underwritten by the drug's maker. In 1986, after a long history of medical studies that had enrolled mostly men, the National Institutes of Health endorsed increased participation of women in clinical trials. That led to the Women's Health Initiative, led by women physicians and researchers, which launched a long-term study of the risks and benefits of taking hormones in menopause. More than 60 years after the launch of Premarin, at least 40% of postmenopausal women in the United States were taking long-term hormone therapy when the study's early results were published. It found that the risks of the most commonly used regimen outweighed the benefits. Hormone treatment did help prevent hip fractures and diabetes, but it increased the risk of invasive breast cancer, stroke, and blood clots. These findings shocked the medical system, and they became a major news story, as I really remember, because I was a Washington Post reporter then. Prescriptions decreased by more than 70%. Hormone therapy does benefit some women, especially in early menopause, but it shouldn't be taken long-term. The study's results stimulated the development of lower dose estrogen formulations and non-hormonal therapies for menopausal symptoms. Since 1990, the NIH Office of Research on Women's Health has been operating clinical trials and longitudinal observational studies focused on women. However, the United States ranks last overall among industrialized countries in maternal mortality, which actually increased between 2000 and 2015, while it was falling elsewhere in the world. Among Black women, maternal mortality is more than 3 times as high as among white women. A racial disparity that undoubtedly reflects systemic racism in the medical system, as well as differences in access to care. There's some research evidence indicating that pregnancy outcomes of Black women are better for mothers and babies when they're treated by Black physicians. Heart attacks and strokes cause more than 1/3 of pregnancy-related deaths, suggesting widespread failure by the medical system to be alert for and detect disorders of the heart and circulation in pregnant women and in the period following delivery. In contrast to other states, California developed interventions to prevent and treat some pregnancy complications and has dropped its maternal death rate by 57% since 2006, showing that we can make progress on this problem. In the last half century, doctors, clinical researchers, and lab scientists have made important progress in women's health. I have some examples of their contributions when it comes to advances in preventing and treating cancer. Decades ago, women with breast cancer had to undergo an operation called a radical mastectomy, removing not just the breast, but other tissues and lymph nodes that lay beneath it or under the arm. It left them disfigured and often with a permanently swollen arm. Starting in the late 50s, surgeon Bernard Fisher first studied how breast cancer spreads and then spearheaded a series of clinical trials in breast cancer treatment. The results abolished radical mastectomy, showed that lumpectomy and radiation treatment led to similar outcomes. He went on to oversee other trials studying the impact of various types of chemotherapy, hormone blocking therapy, and other drugs. Currently, the 5-year survival rate for breast cancer is 90%, although this disease can sometimes recur many years after treatment. Deaths from cancer of the cervix in US women have declined by more than 50%, thanks to more effective and widespread screening with the Pap test. And deaths will probably drop further thanks to the recent introduction of a vaccine for the human papillomavirus, or HPV. This is a common virus that infects young women and young men and can lead in women to the development of cervical cancer. In the US, the HPV vaccine is recommended for girls and boys at the age of 11 or 12. This safe and effective vaccine developed in Australia could probably eradicate cervical cancer worldwide if it were routinely given to both girls and boys. Currently, it's approved in more than 100 countries. Lung cancer is the #1 fatal cancer in women. It kills more than breast, ovarian, and cervical cancers combined. Much of that burden reflects women's past smoking history, since the increased risk of lung cancer caused by smoking decreases after people quit, but remains higher than for someone who has never smoked. Cigarette smoking has declined in both sexes. Currently, it's about 15% of men and 13% of women who are smokers. But it remains the leading cause of preventable disease, disability, and death in the United States, responsible for about 1 in 5 deaths. Smoking, as you know, is also a major cause of high blood pressure, heart disease, stroke, and other illnesses. We still have plenty of work to do on that problem. Heart disease edges out cancer as the #1 cause of death in both sexes. We have modern therapies like the statin drugs that lower cholesterol and can greatly reduce the risk of a heart attack. In our hospitals, we have interventions that can limit the damage from a heart attack or a stroke if they're given promptly. But heart attack symptoms in a woman can be different from the classic symptoms of central chest pain or heaviness, and sometimes left arm pain that men most typically describe. Instead, women may come in with extreme fatigue, indigestion, and neck or shoulder pain, but no chest pain. A woman with a heart attack has a 50% greater chance than a man with a heart attack of getting a wrong diagnosis. And women, particularly those who are members of minorities, remain seriously underrepresented in clinical trials of new drugs for heart disease. Surely, when we're talking about the #1 cause of death in both sexes, these are disparities that we can fix.
So, Susan, looking forward now, where do you see progress in women's health in the near future?
Well, maybe this is the moment to tell you that in 2019 and 2020, which are the most recent years for which there are complete data, women made up more than half of all medical students in the United States. They outnumbered men. In 2019, women doctors remained in the minority among active physicians, with only 36% who were women. But if the trend in medical school enrollment goes on, then it seems likely to change in the coming years, and at some point, the majority of doctors will be women. As for future progress, I think we may gain new understanding about some serious diseases that affect women much more frequently than men. I'm thinking about the so-called autoimmune diseases like rheumatoid arthritis, lupus erythematosus, multiple sclerosis, and others, in which a person's immune system, which is supposed to protect against infections, goes awry and it attacks tissues and organs of the patient's own body. The symptoms and progression of these diseases vary depending on what tissue or organ is attacked, but they can be disabling and even fatal. About 4% of the world population has an autoimmune disease, and 80% of those people are women. Diagnosing autoimmune disorders can be complicated. Cleghorn herself suffers from lupus, and her case went undiagnosed for years, she says, because doctors didn't take her symptoms seriously. I've never heard a full and complete explanation for why autoimmune diseases are so much more common in women. There are also some recently recognized and still poorly understood disorders that have been in the news in recent decades, and these too are more common in women. They include chronic fatigue syndrome and chronic Lyme disease, both of which affect predominantly women, and both of which, when cases began to crop up, were not initially taken seriously by doctors. Commenting on this skepticism in The Guardian, Dr. Julie Nussbaum of NYU Long Island School of Medicine said, "I think certain biases persist, that when women present with a lot of body aches or pains, there's more often an emotional or personality component to it than a medical origin. Now we have a new condition, long COVID, in which some people who survive acute COVID suffer from persistent symptoms that may include fatigue, shortness of breath, chest pain, cough, depression, and difficulty concentrating. 60 to 80% of long COVID patients are women, and they're typically young or middle-aged. What might all these disorders have in common? Surprisingly, an emerging theory actually links women's enhanced vulnerability to their reproductive systems, an idea that would have made Hippocrates smile. Women have more active immune systems than men, in part maybe because they have 2 X chromosomes, whereas men have 1, and many genes that code for parts of the immune system are located on the X chromosome. Also, the female hormone estrogen is an immune system stimulant, and it can increase inflammation, whereas testosterone tends to suppress immune cells and relatively protect men against autoimmune diseases. Women of reproductive age in particular tend to react strongly to an infection with a bacterium or virus because their immune systems have evolved to protect them during their reproductive years. Researchers studying long COVID theorize that fragments of the COVID virus may persist in the body, and in some women, their presence might trigger the immune system and in effect causing an autoimmune disease. Something similar might be happening with chronic fatigue syndrome, which is also called myalgic encephalomyelitis, and with chronic Lyme disease. So maybe Hippocrates was onto something after all. Unlike him, modern medical researchers know a fair amount about hormones and genes and the cells of the immune system. It's possible that studies of long COVID and of these other illnesses that can develop, especially in women after a viral or bacterial infection, will allow us to trace the links between women's gender and their vulnerability to autoimmune diseases, including the more familiar ones that we've been studying and treating for decades. That would be a huge leap forward, and it might help us answer some eternal questions. How are women different from men? How are they the same? And how does it matter? So thank you so much for having me today, and I hope we'll have some questions.
Well, we do. And Susan, thank you so much. This has been, eye-opening in many ways. And some of this, of course, many of us women know. So we're delighted it's being shared. So firstly, what was the name of the book that you reviewed? Someone asked.
Okay, the book is called, I have my reading copy here. It's called Unwell Women. That's the title. And then the subtitle is Misdiagnosis and Myth in a Man-Made World. And the author is Elinor Cleghorn, Cleghorn.
Would you hold the book cover up to the screen, maybe?
Mm-hmm.
And pull back a little bit. There we go.
Okay, thank you. Susan, another question is, what was the name of the clinic where you volunteer and what kind of work do they do?
I volunteer at one of the locations of Mobile Medical Care, which is a network of clinics in Montgomery County. Montgomery County has a number of safety net clinics, but Mobile Med runs some of them. And the work they do is to offer primary care to people who don't have insurance. So when I first started volunteering there, I found out about it through River Road, actually, through a CCNC. And my husband volunteers there too. And the work is primary care for only adults, because kids tend to be covered under federal programs. And it used to be that our patients were citizens and non-citizens, but many of our patients now are immigrants who are not documented or afraid of I don't know, some of them have insurance, but immigrants tend to be a group that's very much still not insured in our country. So I see a lot of uninsured patients who are living in Montgomery County, working, but not insured.
Before I ask the next question, feel free to keep adding questions and comments in the chat. So Lisa asks, so how do you work with people that come to this clinic to counteract their suspicion of the medical system?
Well, first you have to figure out that they're actually suspicious of the medical system, which they don't often tell you right off the bat because they've come wanting care. And I guess, you know, I do speak Spanish, so that's an advantage for me. Many of them are working through translators otherwise, and they like being able to talk to a doctor who speaks Spanish. And that's what I really love, is talking to the patients. But sometimes people don't take all of our advice or all of the medicines that we suggest, or they're hesitant to take other steps in regards to their health, and we don't always hear it from them up front, you know, so you have to kind of find out over time, ideally through having a relationship with them, that they have concerns and they are scared, or they, you know, they are reluctant. I have one patient recently who I discovered had not been taking insulin, even though we thought she had, and she has diabetes. So, you know, things like that can happen. They can happen not just in people from other countries, but, you know, any patient can be hiding things from their doctor or taking medicines that the doctor doesn't know about. So, you know, it's a theme in medical practice.
Mm-hmm. So on a totally different topic, could you explain select issues in the eugenics movement, specifically how they affected women but not men? And were sperm and egg banks existing in the 20s and 30s?
I don't know about sperm and egg banks at all. That's not something that was mentioned in the book. It's a really interesting question. Eugenics affected women and men in the sense that there were sterilizations of men as well as women under some of these programs, particularly in prisons and mental hospitals and in states where, you know, that was a widespread practice. But women, because they were the ones who got pregnant and the ones who were going to be delivering babies, certainly from the statistics I read in the book, had the majority of these sterilizations, you know, because it was thought that it was through childbearing or, you know, controlling who got to have babies that, quote, you know, the population could be improved. That was kind of the underpinning of eugenics. Let's make the population stronger. And of course, it was a huge theme in the Nazi regime, eugenics.
Mm-hmm. A different question, Premarin, what is the source of the drug?
The name Premarin comes, I think, from pregnant mare's urine. It was from originally from horses, you know, female horses that had high hormone levels. They would isolate the hormone from their urine, and that's where that name came from. I think that eventually it began maybe not to be that source, and was hormones in general were started to be able to be produced in chemistry labs instead, but originally it was pregnant mare's urine.
So I have a question, and that is that for so long, new drugs were tested only on men. And obviously men and women's bodies are different. The dosage for men would undoubtedly be different than for women, but we didn't know this because women weren't being tested. Are they now more equally being tested for new medicines?
Well, that study that I quoted about heart disease shows that they're not equally being tested in women. It was a recent study, I think from 2020, that's cited in one of the articles in my sources. And I think, you know, part of the reason that women were so long kept out of clinical trials was this whole business of hormonal imbalances. You know, researchers said, oh, well, their metabolisms change over the course of a month because their hormones go up and down and things go up and down, and we don't know how that's going to affect the drugs. So we're just not going to include them because we don't want to muddy the waters. But that meant that women's bodies weren't really, women were not subjects for a long time as a rule in trials, and pregnant women are even less likely to be subjects in trials because everybody's afraid of damaging the pregnancy or the baby. But sometimes pregnant women need to take medicines like everybody else. And we need to know if drugs are safe to take during pregnancy or not. And that can be a real conundrum. It's not equal even now. I think the NIH is continuing. I've read that they are committed to equalizing the numbers and including women in their trials, but they still do not succeed in getting sufficient numbers of women of color into trials. It's hard sometimes to recruit women of color, but I think they have to do a better job, because that's part of that helps to sort of contribute to the health disparities among the races that we are becoming so aware of now, the fact that we don't have enough information.
Mhm. Now, here's an interesting question. Would you be willing to comment on what you think is the most egregious medical error that underlies the Texas abortion law?
Well, I don't know what the most egregious medical error is, but it makes me think of an article I read while I was preparing for this talk, and it's from a few years ago, but it's by an ethicist named Alta Charo, who talks about the fact that the state legislatures, in passing laws like that, and going back to even passing other abortion laws in the past, like the one that outlaws certain kinds of late abortions involving surgery that people find awful, but that sometimes are, used to be necessary. They introduce language in the legislation that says it is a medical fact that babies start to feel pain when you're only at 6 or 8 weeks of pregnancy. Well, that's not a medical fact that anybody has ever been able to show. A fetus in the very early weeks, there's no evidence that the nervous system has progressed to the point where pain is possible. But things that are called medical facts are introduced into some of these bills. There's a requirement, I think, in one of the laws that people have to have an ultrasound, at 6 weeks gestation before an abortion. A lot of things that are sort of called upon as medical facts that are not actually medical facts, but the legislators write them in as if they were. And that seems egregious to me. And I think this article explains it better than I did. Maybe that can be added to my sources, because I don't know if it's on there.
So Chris Hager asks, she says, somewhat in jest, I have suggested that if women do not want to carry a child to term, there should be a way for men to have the embryo implanted and carry the child to term.
I like that idea. I think if men, like, there was a poster, we went down to the march yesterday, and there was one sign I saw that said, if men got pregnant, abortions would be available on ATMs.
Yeah.
Just, it was funny. But
I was there too, and there are a lot of signs that says no uterus, no opinion.
Yeah, I saw that one too.
Many of them. So speaking of men, Rob Neuter asks, he says, this may be an unfair question, but what do you make of the fact that in our liberal congregation, the rate of participation by men in this presentation is about 18%? Obviously, he's been doing his math here. So in other words, it's a low participation in this very important topic.
Well, that's news to me, because I haven't seen the statistics on who came to the talk, but I guess I'm not surprised. I think women know a lot about their own health experiences, and women have a lot of stories about times when they had a good health experience or when they thought that a doctor didn't listen to them. And sometimes the complaint, Cleghorn says, very often the complaint is the doctor didn't really take me seriously. So I would have expected that it was mostly women in this audience. And thank you all for coming, whoever you are.
And yes, it's something that we need to make all of these issues both men's and women's issues. It's not just a women's issue, obviously. Chris again asks another question here. One concern about abortion is that many abortions are spontaneous. How can spontaneous abortions be distinguished from others?
A spontaneous abortion is another name for a miscarriage. And that's when the body itself stops carrying on the pregnancy, and a woman loses that pregnancy. It starts with bleeding usually and alerts the woman that something is wrong. Sometimes she might have pain depending on how far along in the pregnancy it is. But it's, even though it's called a spontaneous abortion, it's not the kind of abortion that not Congress, but people in Texas and in other states are trying to outlaw. It's a medical event that can't really be prevented once it gets going.
So let's see. That's all the questions that have come in writing. So maybe what we'll do is open it up to see if someone would like to
No,
ask.
you can't jump out the kayak.
Pardon?
Because they're not hard-sided, so they can't
Can we
Well,
ask everyone to mute,
bring
please?
them all the way down and they'll fill with.
So-
Jane,
Everybody, if you would like to ask a question, can you go into the reactions button and raise your hand?
Hey,
And then could Jane and others, could you mute, please? So we don't hear. Carl, you can help me see raised hands because I can't see them.
I like being in the water, but I don't want to get back in the
Okay,
water.
Carl, you can mute everybody.
I'm
Could
dry
you mute
now.
everybody?
But I will say, after like 4 minutes in the water, I could have stayed in the
Okay,
water.
Jane, could you mute, please? And Carl, our tech person, will try and
Bad.
mute everyone. So now we're opening it up to live questions. If anyone has a live question, would you like to raise your hand?
You just take the pillow off.
And I'm not seeing any yet.
Maybe switch out.
Carl, do you see any raised hands?
See it got,
Oh, Carl has his hand raised. So go ahead and unmute. You have to unmute.
I guess I can leave now.
Jane,
It's
if you could
Q&A.
mute.
I just did. Susan, could you explain maybe some of the more advanced medical treatments that women in Scandinavian countries have that have developed over the years because of also maybe of being understood there's been an imbalance of women versus male body research?
I don't know about that. I haven't read about that. It's, I would be interested, but that's not something that I came across.
I'm wondering if the American social movement with women, starting, of course, most vocally in the last century with rights to vote, whether much of these issues have brought women more out in the public forefront, where in a more socialist system where everything has been equal, the woman's voice is not as a overt, effective form of, progress.
I'm not as familiar as I should be with the different things that are done for women in European systems. I will say that there's a lot in the Cleghorn book about how the suffrage movement, the movement on the part of both white and Black women to get the vote, universal vote, made a big difference to women's cohesiveness and their ability to fight in other political ways. And when there was a women's health movement that started in this country in the earlier part of the 20th century and then continued on into the 60s and 70s, there was a corresponding Black women's health movement that started. And it was very interesting to read about it because women said that they had always culturally been told to keep their private stuff to themselves rather than sharing it. So the first big conference of the Black women's health movement involved a lot of sharing and sort of bonding between the people who attended, the women who attended, and created sort of a new force, I think, for healthcare for Black women. And, certainly in this country, there was a push to get access to birth control. There was a push for the legalization of abortion before Roe versus Wade happened. There was a lot of political activity that went on in New England and other parts of the states. I think that in Scandinavia, because they have socialized care, and they also have a lot of other benefits like much better they have, universal insurance, and they have universal pregnancy leave that is much longer than what's usually available here. They have support for people with children, and that exists in some other European countries as well. There are social underpinnings that make it easier to have children and to work and to be at home as a mother. But as far as medical advances, I'm not sure what they have in Scandinavia for women. One thing I know about Holland is that they have training for older women and men on how to fall to prevent hip fractures and things like that. They have actual, gyms where you learn how to fall safely.
And one question carrying on with that theme, I heard 2 or 3 years ago on an NPR book interview with a female journalist from Cairo in her early 20s, how she was bringing out through all the Arab women, the Arab world, about the suppression of knowledge that young women have about their body, and they probably have never even understood what their lower areas look like. And it's just an incredible awkward experience for women late in life, including later in life when their first time and their married evening, to not be prepared in so many ways because they don't know their body. And I'll close with that comment.
Right. I'm sure that's probably a prevalent problem in Arab countries. I think that it was probably a prevalent problem in the 19th century in Europe and America too. And when the women's health movement started and when Our Bodies Ourselves came out, a lot of the focus was on teaching girls and women more about what their anatomy was like and what their cervix was. And people were looking, with a light and a speculum to see what was in there. And it was like a revelation. But I think sex education is still, not available to teenagers or, young girls in a lot of schools and in a lot of systems within our own country. There's a lot that girls don't learn, or whatever they do learn, they may learn from other teenagers, not from people that can sort of help them understand what their bodies are all about.
Yep, and the lack of sex education and reproduction is not taught in some Catholic countries and countries that I've worked in Central America, and so it's a big issue and needs to be expanded. I'll turn to Chris Hager. So Chris, please unmute.
I have a couple of follow-ups. One is that, yes, I know the difference between spontaneous and induced abortion. How will the courts decide that difference? And secondly, and I asked this question very early, many years ago, during the height of the HIV/AIDS epidemic, some female researchers were working on an antiviral cream for women to use because men were refusing to use condoms. Has anything happened with those kind of treatments? So those two questions. Thank you.
If I'm not mistaken, there's a pill there's a program called the PrEP program that involves taking a pill to prevent HIV infection. I think it's a daily pill. It may be confusing it, but I'm pretty sure there's a prevention drug that men and women can take to prevent infection, and it's been marketed very much for men who have many partners, but I believe it's probably also used for women who have many partners. I wish I had the name of it, but I think that the drug that is used for that purpose is available to both sexes, and it's been studied, all around the world in both sexes. So yeah, that exists. I think that courts, when they talk about making abortions illegal or banning all abortions after 6 weeks of pregnancy, which is the ridiculous deadline in that Texas law, they're talking about induced abortions. I guess, Chris, you may be asking if a woman comes in and says, well, I had a miscarriage, how will anybody be able to tell the difference? That's a good question. I don't know. But, I think as far as the legal language goes, they're talking about induced abortions. Maybe some women could say that it was a miscarriage, and that might be a defense.
But how will their neighbors or somebody else make that distinction and report them and have them go through the whole horrific legal process?
Well, I think this whole question of having neighbors and people in this community report them is just, so flawed to begin with. I have no idea how you would make a case as a neighbor against anybody. I just think it's outrageous.
So Mary had a question. Mary, please unmute.
You talking about me, Mary Lou?
Yes, I'm sorry, Mary Lou.
Okay. I wanted to know, does the Montgomery County clinic system ever use or need licensed psychologists for volunteers?
Yeah, I'm pretty sure they do. At Mobile Med, we have some psychologists, but all of these safety net clinics need people with special skills. And if you're interested, I'm sure that I can help you get in touch with places. If not Mobile Med, there are other ones too. There are other safety net clinics, and I'd be happy to help you find somebody who would be interested.
Yeah, I don't speak Spanish, but I would be interested in finding out what clinics and what kind of needs.
Sure. Mobile Med has counseling of various sorts, and they also have a program of motivational interviewing that's available to try to help patients become more understand their condition, like high blood pressure or diabetes or whatever, and to increase their motivation to take care of themselves or to become healthier.
So we only have a few more minutes. So if you have another question, raise your hand while you're thinking of it. Let me say that I didn't know, Susan, that women experience long haul COVID effects more than men do, but I was very pleased that NIH has received, I think, $1 billion to research long haul COVID, which of course will affect some chronic fatigue and some of these other diseases. So hopefully the findings will be beneficial for women and for everyone, but particularly for women.
I didn't know about the connection either until Diane Bean alerted me to it and sent me an article from The Guardian. And really, it's become kind of an area of research to try to see whether the existence of antigens or parts of viruses that might remain in the body can trigger these autoimmune reactions in patients, and maybe more in women than in men. So I found it fascinating.
Are there any more questions from the audience? I don't see any in the chat or hands raised. Susan has kindly listed a range of resources or sources that she used for her talk. And we can put that on the screen for a minute so you can review them. If any are interesting to you, you can follow up with them to learn more. Okay, Carl, why don't you go ahead and show those sources? So you'll see, okay, well, this is, okay, you want to go to the sources? He's trying here. There we go. There we go. We have 5 sources here. And then we have just leave that on for a second so people can read them and write down authors' names, etc. if you're interested to find out more.
I just want to say that number 5, Physicians and the Woman's Body Politic, is this very interesting article about the writing into legislation of, quote, medical facts that aren't actually medical facts, to justify some of these laws. It's a very good article.
And then there's one more slide. Carl, you want to go to the next one, the rest of the sources? There we go, 6 through 9. So we thank you. This is the next program in our Contemporary Issues Forum series. Again, Sunday, October 24th. Note that down. You'll learn more in the e-weekly. Susan, we want to thank you so much. This has been very insightful, and we appreciate all the work you've done to be able to put this together. So, and thank you all for participating.